welcome everybody to this evening's Sustainable Pharmacy Network event. And we're joined by Laura Stevenson, and we'll be hearing from her in a moment. Great to have you all here with us this evening. Do feel free to say hello in the chat. We have set up the Q&A, so you can use the Q&A during the presentation to post questions for Laura. Hopefully you can all see my slide at the moment. Just a few sort of ground rules, if you like, in terms of the network. We really encourage you all to join our Sustainable Pharmacy Network. And our community will have time for discussion and questions afterwards. So please do sort of engage in a professional manner in our discussions. We're all here to sort of engage and learn and share and collaborate. So we want to all work together. Just to encourage you, if you haven't already, to please join our Pharmacy Sustainability Network. We set this up about 18 months ago. We've got a really active network, lots of people joining from all around the UK and Europe and further afield. It's free to join, so you can just scan that code. You just need to register with the network, which is free. And then once you're registered, you'll get an email to say you're registered. You just log back in and then sign up to whichever networks you wish to sign up to. Obviously, the pharmacy network, and there's lots of other networks as well around professional areas and specific clinical areas as well. So please do join our network. We will be sort of posting information about this event and the recording on the network, and future events also. There's also sort of lots of discussions, resources and case studies in relation to sustainable pharmacy on the network. So a great resource and a great place to meet like-minded people. So without further ado, I am going to hand over to Laura Stevenson. Laura is going to speak to us tonight about the work that they're doing in King's College London Hospital around reusing medicines. So over to you, Laura, and thank you so much.
Thanks so much, Nuala. I'm just going to share my slides. Perfect. So hopefully you can see those.
Yeah, thank you.
Okay, great. Thank you. Thanks for the introduction, Nuala. So as Nuala said, my name's Laura. So I'm a pharmacist. I'm an aseptic pharmacist by background. So I've worked in aseptic services for many years. I currently lead the service at King's. And I'm also the medicine sustainability lead for the trust. So my two hats. My talk today is going to cover general aspects of medicines return and reuse, what we mean by this, when it's appropriate to do so. And I do have some examples that are mainly from an aseptic point of view due to my knowledge and experience in this area. And much of this can be replicated in other areas of pharmacy and other services as well. So, oh, there we go. Next slide. So yes, obviously, I'm sure everyone has seen these slides. I don't think it's possible to do a talk on sustainability in the healthcare without these slides. So the NHS is committed to net zero by 2045, and this is the first health system in the world to do so. So what are we actually doing to achieve this? So for the NHS in England, that means net zero by 2040 for our carbon footprint and net zero by 2045 for our carbon footprint plus. And you can see from these slides what that means. And also the things I've highlighted on the left-hand side of the screen is that medicines account for 25% of the NHS carbon footprint. And that means we all need to do our bit to reduce these emissions. And actually, it's in fact mandated by all green plans that we do. So that is why every NHS trust has a green plan, every ICB, every hospital, every integrated care board has its own net zero strategy. And that means that we are all responsible for achieving net zero. So hopefully this talk today will give you an idea of how you can help, because every little bit and every little area that you're an expert in will massively help. And certainly as pharmacy professionals, we need to look at where our biggest impact is, and that is, of course, medicines. So I'm going to start by talking about tackling waste as a starter. So the ideal is to mitigate waste in the first place, of course. So actually, whilst recycling is great, reusing is great, which is what we're here to talk about today, the biggest R and the best R of tackling waste is reduce. Can we eliminate the waste in the first place? So we all know of that urgent medicine that's needed for a patient, sent to the ward in a panic, you've got all those phone calls happening around you, but actually you go to the ward a few days later, it's not been sent home with the patient, and it just ends up in that big yellow pharmacy waste bin. So actually, let's start this talk with thinking about, do we actually need to use the waste in the medicine in the first place? So reducing our waste is the absolute best R. But of course, the next step down is reuse. So return and reuse of medicines. So the obvious reason that we would want to reuse medicines is because of the wastage of costs. The NHS is in dire financial times. I don't think that's a shock to anyone. Waste of resource. We know as the staff of the NHS, we're already so stretched. So thinking about the thought of repeating work is not only an additional burden of our time, but it's also really frustrating. And I know from personal reasons, it can really affect morale. It's a very time-consuming process, especially if you're looking at something like aseptic manufacturing, like dispensing. It's a huge extra burden to have to give to our staff. And of course, wasted materials. Single-use plastics are heavily used in dispensing and in pharmacy, and we're not only adding to this, but just burdening ourselves when we're not reusing medicines. So we're already seeing an increase in work year on year with people living longer as well. But how can we work smarter with a finite resource? So we know it's unlikely that we're going to get more staff to help us with additional work. So efficiencies are key to ensure that we're utilising the capacity that we already have in the most effective way. So reuse of medicines. So this is a PJ article from a few years ago that's discussing this very topic. So that just goes to show it's been a long-standing question. Should we be reusing medicines? There are a few health systems in the world where medicines have left the custody of a healthcare provider, remain unused by a patient before being returned, and assessed for quality before being supplied to another patient. So places like Spain, places like Greece, they do this routinely. So many of these schemes have shown success and promise. They either all focus solely on high-cost medicines, meaning the effort into administering the scheme pays off, or where access to medicines is reliant on insurance or out-of-pocket expenses, meaning medicines reuse schemes improve access. So it is a big question, and this is a paper from, I think, around 2020, which I would encourage you to read about should we be allowed to reuse medicines. But in the UK currently, this is a statement from the MHRA, and this says that it should be obtained from a reputable source, safe and fit for purpose, stored securely. So basically, in the UK at the moment, we are not allowed to reuse medicines. So I'm probably taking this out of context slightly, as in hospital reuse is slightly different to medicines being kept in a controlled environment in the community. But I suppose my question is, can we ever guarantee the safety, quality, and efficacy of medicines we send to the wards? Because ward stock, anything that's based on the ward normally, they're always there. So actually, if we're taking something back from the wards and repurposing it, we'll always get the question of how can you ensure that actually it's been kept in the right environment? Well, how can we ever guarantee that? So everyone will ask, why are we compromising safety standards? Well, we aren't. So what do we mean by return and reuse? Well, generally medicines are inherently single use. You can't reuse a tablet or an injectable dose. So the definition of return of medicines is return of medicines to stock which haven't left the hospital premises or been outside of the possession of hospital staff. So of course, I think it would be a bit rogue to say we would let a patient leave the hospital with the dose and then try to return it back to stock. This is talking about medicines that stay within the custody of a hospital. And reuse, we're dispensing or administering a medicine or dose that was initially intended for one patient and then giving it to another after the appropriate checks. So I think what's really keen to highlight here as well is we are making sure we're still vigilant around this process. So we still need to do our safety and quality assessments. We still need to make sure that we're giving a medicine that's been unused, intended for one patient to another, rather than disposing of the dose. So we have found that often the most efficient route, which ensures the highest likelihood of use, is returning the medicine to stock, sometimes with appropriate segregation or highlighting to ensure it's reused appropriately. So essentially, we're bringing that medicine back into our stock. We're making sure it's clear that this medicine has actually returned from stock and then figuring out if it can be reused for a patient. But of course, going through those very important touch points and checks that pharmacy already has. So the dose must be dispensed again and must be checked again. It's not something that you can just take back and give out again. We must ensure those quality checks are still present. So what have we done at King's? Well, I'll tell you more. So King's experience. So this is, like I said, primarily based around my experience with working from an aseptic point of view. So we did an audit around patient experience delayed doses on CDU, which is our chemotherapy day unit. So we found that actually a lot of our patients found that there were massive delays in experience. And that was because we had a standard around a 72-hour agreed notice period. And adherence to the notice period wasn't happening. It was only around 7%. So we're actually looking to improve our patient experience around being more proactive in seeking of prescriptions. So we know that actually simple things like return and reuse will massively benefit our patients. So any drugs included were chemotherapy or immunotherapy products with over 48-hour expiry. And our stakeholders were things around governance, our CDE nursing staff, our pharmacy research and audit group, which are always great if you want to pilot something like this. And we've also now engaged with other hospitals on this type of model as well, who are keen to adopt it. And something else that I've mentioned here is that I've put a paper at the bottom of this with a link, and it's a 2009 paper. And I wanted to include this to sort of show this isn't novel and this is not new. This is something that other countries routinely do. It involves trusting healthcare professionals around us. And it involves the fact that we're all here for one common goal, and that is helping our patients get better. We're putting the patient at the center of all that we do, and that ensures we remember that simple things like this can make a huge difference to our patients. And I'm sure everyone has seen and will hear the news. 97% of treatment centres are affected by cancer care delays. It's a huge thing in trusts around cancer waiting times is always a metric that we track. So it is little things like this which will make a huge difference. So when can we return and reuse products? So this is a bit of a boring slide, but this is the how we do it. So we must have defined criteria to do this process because we cannot compromise standards, quality, or safety. So there's a list there of products that might be returned and reused and when that can happen. So we need to ensure that all products returned to pharmacy meet these criteria. And they're kept segregated from other products whilst they're in a reusable state, so you know that these are products that have been returned. So once a patient is identified to reuse the product, it must go through dispensing and checking again, as I said previously, as per your normal processes. The product must have identification from the previous patient as well, so dispensers can see that it's a product for reuse. And this must be over-labelled for the new patient. So it's really important that we still have that criteria from previously so that we can see it's a redispense and we're just being as vigilant. We're actually over-labelling it. We're not taking that previous label off because we always need to make sure we have that audit trail. So the paperwork must also make this very clear. It must have the previous batch number and the new batch number, and it must be identifiable again for that robust audit trail. And then the final checker as well, so you'll always have a final check, must review all of the information in collaboration on final check. So this is just to say that we're not compromising any of the standards that we currently have. So this process obviously can then be more complex. You might have a bit more paperwork. So care must be taken. And it's certainly advised if you do adopt a process like this to have it on induction and in training periods. If you're going to adopt this, we also do additional logs for return and reuse products for our new staff, just so that they can get to grips with that. So the first time they see it is not in the first couple of weeks when it's something they're not clear about. So a local risk assessment. So this is obviously key as well. So a risk assessment is essential, which details the risks against benefits and understanding if the risk reduction is needed before we can start the process. So you detail your risks and you decide, actually, is this safe? Do we need a risk reduction? Does something need to change first before we can start this process? And also asking questions like, does someone need to own this process? So we at King's have actually found it really good to make sure that we always have one person working on this, whether you put it on a rota, whether this is just part of someone's job description, so they know exactly what you have returned from the ward. You've taken that back into stock. They have a log, they have a list, they have a spreadsheet of everything that's on there, so that can be managed. So things to consider for your risk assessment. So storage. So you must have a reliable storage area with continuous temperature monitoring. So I know in hospitals this is a very common thing, but not necessarily in all areas. So just making sure that actually if the product was a fridge product, making sure we can say it's reliable storage, that's somewhere that we know has been kept within the right 2 to 8 degrees. And also if it is something high risk or hazardous like chemotherapy, it should always have been stored in a locked cupboard just so we can ensure it's not been tampered with. Staff training. So this is going to be key. So staff will need to be competent to undertake the process, and they must be competent to relabel and reuse the dose for another patient, and pharmacists must feel confident checking a reused dose as well. And this goes for pharmacy staff as well as ward staff. which brings me on to the next point around communication. So communication is absolutely key between all areas. So we need to make sure that we have a really good relationship with the staff that we're accepting returns from. So we need to know that they can tell us accurately where it's been stored. Not all products will be able to be reused, and that's fine. But as long as we know that we can, when they bring them back down, they say, this has been stored here, we know it's safe for reuse, because we have to have that communication. That relationship is key. So on to some of the benefits around it, of course. So cost savings, let's be honest, in the current climate, if we want to complete a new project in a trust, there has to be cost savings before anyone will even entertain listening to you. There's 3 magic letters, CIP. For anyone that works in a trust will understand. So one of the big advantages to reusing medicine is, of course, the cost savings associated. So depending on the type of products reused, and what falls into your category, it can add up to quite a lot, because every little really does help with this sort of thing. So dose-banded products with good stability are those that are likely to be reused. A lot of these products are high cost, things like monoclonal antibodies, which is what we have seen at King's. So they're generally very stable, good stability, and we have had monthly savings between £5,000 and £10,000. So our 24-25 cost saving end of year predicted will be £91,412.33. So appreciate we're not at the end of the financial year yet, so we're not quite able to 100% confirm that, but that's what we're looking at. So obviously that is a huge amount of money, and a huge way to get your foot in the door with a project like this. And it isn't all about money, but it is a really attractive thing to say, actually, this is not only going to save you time and resources, this is going to save you a lot of money. Of course, from my experience, we've done it with things like monoclonal antibodies, but doing it anywhere in a dispensary as well. We know there's high cost drugs everywhere. The carbon impact. So while we're giving a talk here at the Centre for Sustainable Healthcare, we of course have to consider the carbon impact. So another huge advantage is reducing our carbon footprint. So we've committed to net zero in the NHS, and to achieve it, we all have to play our part. It's mandated in your green plan, and projects like this will also help your sustainability team reach their goals. Your sustainability team in your trust will have goals that they have to reach. So certainly medicines, like I said at the start, account for 25% of the carbon footprint of the NHS. So projects like this can massively help boost that, and it puts it on everybody's agenda as well. So from my point of view, again, from a hazardous medicines impact, it's greater than any others. We use a huge amount of single-use plastic in these processes. Our cleaning products are very burdensome. High temperature incineration is required for our waste process, as is all medicines. And so I think living this on a day-to-day basis as well, and you'll probably know from your own staff, anytime that you ask someone to repeat something, it's just hugely deflating after you spend so much time and effort on one process, especially when you're busy. Having to repeat it is not ideal. So the benefit here is certainly outweighs the risk in my point of view. So capacity impact as well. So looking at our capacity, we know the NHS is struggling. Almost every team is stretched and over capacity, and we're doing more work with the same amount of resource. So I think return and reuse of medicines can help alleviate some of this pressure. It reduces down the most burdensome part of preparing a medicine. In this current era, we have to think of ways we can keep safety standards whilst being pragmatic about historic processes that may have worked in the past, but are no longer in the best interest of our patients. So we all know those people that will tell you, this isn't how we do it here, but that's not always a good enough reason. And we certainly have to maintain that risk assessment, look at our quality and maintain safety standards, but actually asking, why are we not doing this? So why are we keeping patients waiting longer in a bed than needed? Why, when patients could go home, when patients don't want to be there, are we keeping them in hospital when actually we could send them home? So the UK SAC Board has released a paper in 2023, which is titled The General Principles Support SAC Therapy and Capacity Pressures in Aseptics. And this just talks a lot, has a good section on it about repurposing SAC to support reduction in waste, but also supporting our patients and reducing delays. There's so many products that are dose banded that actually perfectly fine for a lot of these patients, because they're unwell, they can't go ahead for one reason or another with their medicines, so returning it back to us for us to be able to quickly dispense that out again to patients to save them waiting is so crucial. So just on that, then on to patient experience. And this is arguably the most important reason and advantage of this project. And this is why we started it at King's looking into it, was because of the patient experience. And from our survey, we found around 25% of our patients were facing delays in treatment, which is just simply not good enough. And we wouldn't appreciate if that was our loved one. So many delays in the system. If we can help reduce down some of these, it could have a huge impact for them in their treatment. We know how morale can be affected for these patients when they're cancelled or delayed. A lot of our patients take a full day off work to come and get treatment. It means you have to take another day off, having to come back a different day, traveling a long distance to get to the hospital just to be delayed or cancelled for whatever reason. It's just not good. So if we can help in any way, we absolutely should. And we know that delays also affect patient experience by lengthening their recovery times, prolonging their admission to hospital. It leads to avoidable patient harm as well, and affecting patients' mental and emotional well-being. So next steps. So if you want to try this, you absolutely should. So my advice would be create your pitch on this. Mine is obviously very tailored towards aseptics, but there's absolutely no reason that you can't do this within your trust for any area that you work in. Definitely create an audit on medicines wastage, look at the data, gather the data to show actually this is the amount we're wasting, this is the amount we could be reusing. And QA projects always a really attractive thing as well. If you have a research and audit team within pharmacy, go to them to help you create this pitch. So do your risk assessment as well and involve the staff who'd be carrying out the work, just so that you can get appropriate sign-off and people are actually on board. And obviously run it by the key stakeholders as well. So I'd highly recommend having quality assurance advice on this kind of thing, and just being able to discuss those risks around quality and safety standards of medicines. So further benefits. So further benefits are, of course, more staff are aware of the sustainability agenda, which, as discussed, it's going to be everyone's issue to solve. We all have to work together to achieve net zero. So creating projects like this involves basically anyone in your team and anyone in pharmacy. So it's bringing them together to put this at the forefront of the agenda and make people understand the problems that we're creating by all this wastage. A SIP plan as well, which is really a big topic of discussion at the minute, and that will help the trust achieve the green plan, but also save money. So I can't see why anyone would not go for it. And of course, making medicines wastage a topic on everyone's the agenda. And that is it. That's all I have today. I've got my email there. If anyone has any further questions, I'm happy to send over things like we have SOPs and risk assessments and things like that if anyone wants to know more.
Great. Thank you so much, Laura. And you're getting lots of rounds of applause there in the chat box. Does anybody have any questions? If you'd like to put your hand up, there's nothing at the moment in the chat or the Q&A. So please feel free to either write in the chat or the Q&A, or put your hand up if you have got a question. So I'll just give people a second to do that. You've answered one of my questions, Laura, because I was going to ask you, do you have kind of an SOP that you can share with people? But you've just said that you do, so that's fantastic.
I do. Yes, of course.
Great. Paul, go ahead. Do you want to unmute?
Yeah, thank you. Great presentation. Thank you very much. I work in a hospice, so drugs get dispensed to us. I'm guessing if we wanted to do something like this, we'd have to send them back to pharmacy. We couldn't just relabel them where we are.
I mean, interesting question. I suppose all medicines obviously come from pharmacy in the first place. So I suppose from the quality hat on, yeah, the best thing to do would be send them back to pharmacy and they can put them back in their stock and reuse them. I wouldn't say it's a no, though. If you have something on your ward where you have access to relabeling medicines and it's got everything you need, like the patient details on it, that seems appropriate to me. I would always say undertake a risk assessment just to cover yourself, because then you have that audit trail of the why. You can give the evidence to say, actually, we discussed this with our pharmacy colleagues and we decided instead of adding more work to their very busy day, we've made our own risk assessment to say we have the appropriate facilities on the ward to do a relabel. We'll do the patient details. I can't see why that would be a problem. I think as long as you discussed it with your pharmacy. and made that clear.
You can probably tell I'm not a pharmacist, so I apologise for asking this question.
No,
when you say the facilities to relabel, what do you mean?
Sorry. Like a labeling machine,
Like
a computer, your software. So pharmacy tend to have software that create patient labels from that database. So for example, at King's we use Epic, which is one good thing about Epic is that it's unique across the wards. We can do labeling on wards, and that actually might be something your pharmacy can help with as well. We do on-ward labeling as well, so that could be something that if actually they can just take that on board as well and say, I can see all these medicines, instead of returning them back to pharmacy, I'm just going to have a look if there's anyone on the ward I can reuse this for. It could be something that could help with.
Okay, thank you. I have a feeling Paul may have frozen, but I think you fully answered his question. Thank you, Laura. We've also got Catherine. Hi, Catherine.
Hiya. I'm not a pharmacist as well, so Paul wasn't the only one. I'm sorry for infiltrating, but it's great to hear the work you're doing. Really interesting. I suppose, and this may be covered by people who know better than I do, but I'm interested to discuss how this could be used as a process in primary care. So I'm thinking about community pharmacies, and could you enlighten us at all, or is in the room who could?
Yeah, I mean, very happy to touch on it, but if anyone else is more of an expert, I've never worked in community pharmacy, I'll hold my hands up and say, but currently, as per one of my slides, which sorry, I may have rushed through at the start, it isn't the MHRA do not allow you to return medicines to pharmacies for redispensing. It is not allowed in this country at the moment. However, it is done in other countries, so I think that's to say hopefully in the future things will change around that. But I guess with my sustainability hat on, the only thing I can say is to encourage people to return their medicines to pharmacies anyway, because then we can appropriately waste them. Because we do see a lot of medicines wasted from routes that maybe aren't the nicest. We did a survey at King's on medicines wasted as well with this, and we got a surprising amount of people who were flushing medicines down the toilet. Appreciated the honesty, it's good to know, but I think from a primary care point of view, I guess for now the best thing to do is encourage people to bring your medicines back to a pharmacy so we can ensure they're wasted appropriately instead of being put into things like landfill or our water streams.
Thanks.
Just to chip in there, totally agree with that, Laura. Another thing that lots of areas are doing now are encouraging community pharmacies to tell the patient to check the bag before they leave the pharmacy. So usually you'll get handed a sealed paper bag in a pharmacy, and if the patient opens it up and checks everything in there is what they need, if there's anything they don't need, if they hand it back before they leave the pharmacy, then it can be reused. It's as soon as it leaves the pharmacy, then it can't be reused. So that's another just quick and easy one, particularly for patients who are on to the polypharmacy, repeat prescriptions, and stuff is getting ordered month on month on month. If the stuff they don't need in there, they can give it back. So that is one small move to make. Helena.
Hi, thank you. Really great presentation. I'm not a pharmacist either. I'm a paediatrician, but I lead in Nottinghamshire. Laura, your savings at King's, was that just for your MABs, or was that for all the drugs that were recycled at King's?
So that was for all the drugs aseptically prepared that were recycled at King's. So we haven't, I actually tell like we have done this with normal medicines as well as aseptic medicines. It's not something I was a part of because of my role, but we actually used to at King's, sadly not anymore, but we did employ a band 2 ATO whose job was actually to go to wards and find medicines that could be returned. So I know that whilst I know more about the aseptic side, I know this is possible in other areas as well. So something like a band 2 ATO, it's the sort of cheapest band that we can get, and their job was to go around all the wards. They had a rota and they would go there and they would find medicines that were patients who had gone home, and they would appropriately look at the ones that could either be returned to stock or ones that had to be discarded. It's also a huge burden off the nurses, so they didn't have to deal with all that waste of medicines as well. And anything that could be, they would just return it to pharmacy stock. So it would go back in the robot, it would go back in the fridge, it would go back to where it belonged. So that would just go back into the normal stock work stream. So if you needed that drug for another patient, it would just come out the normal way that you expected it to. It wouldn't even be thought about twice. It was just put back into stock. So I know it is possible for all medicines. It's just investing that resource in doing it. And the reason they actually got that post funded initially was because they proved how much money you could save.
Right.
This post might cost X amount, but the savings are actually much greater.
Yeah, brilliant. Thank you.
problem.
Just on a point to Nuala as well, you know, this is it to us in the room, the metaphorical room, it's a no-brainer, isn't it? How can we push this out? Because, you know, it's a brilliant project. We need to be tearing down the barriers and making these things happen. And I think we really need to push our chief pharmacists to adopt this and not find barriers. So I think there's a challenge there, and maybe I don't know if there's anybody from NHS England, but that's we just need to make this happen, don't we? We've, you know, Laura's beautifully described the safety of this, the pathway, the care that it's taken, the benefit to patients in terms of the oncology stuff. So, you know, we have to ask ourselves, why wouldn't we do this? And sometimes it's too difficult, and we need to be able to make that happen. So that would be my challenge to us all, is how do we collectively make this happen? Because we have to. Thank you.
Yeah, absolutely agree, Helena. And I mean, that's part of the reason why we want to have these events and sort of share them as widely as possible. And I guess one thing I was going to ask you, Laura, is if there's a kind of a summary of this that we can post on the network, because again, that's something for people to kind of can access again. But yeah, absolutely, kind of we need to be taking this back to kind of clinical settings and raising it with chief pharmacists. Just picking up on the cost calculation, Laura, Helena just reminded me of a question I had. When you calculated those costs, is that purely just on drugs cost, or did you also take into account the savings of not having to pay for waste disposal of those drugs? Because that's a separate cost that's often sort of treated separately because it doesn't come from prescribing budget, so it's often left out.
No, a very, very good point. That is actually just drug costs. So drug and the associated like dilution, maybe like a saline bag. But something that we didn't include because we thought it was a bit tricky to do is things like you said, other costs associated, like staff time. We didn't go down to that nitty-gritty, but if you wanted to, you could definitely quantify staff time as a saving, and also things like screening and dispensing fees. So certainly production units do it, and I know that some other areas do it, but things like your time for screening and dispensing fees, those are on costs that we actually charge to NHS England. So those again are things that would be doubled. If you're remaking a dose, you're technically screening it and dispensing it again. Those are just more costs in the system. If you're using that dose, we can't charge that again. So it's things like that which just add up. There's so many savings around it. The cost of like how we transport waste, the cost of like incineration of waste, that's not included in my figure. So I think it's a lot bigger than that, and you can grossly overestimate things, but I think there are definitely costs to be added on to that as well.
Yeah. It strikes me that it would be really great to apply the SysQI methodology to this piece of work, because I thought it was really interesting that it was actually the patient experience that motivated this work in the first place. And that's so significant, and that's kind of looking at the social impact. But then, like you say, it has the cost saving that enables it to get done, which is great. Okay.
I think as a pharmacist, if you sometimes feel like you have, and probably this for anyone on the call here, when a doctor or anyone who tells a patient they can go home, and then they're told they have to wait 4 or 5 hours to get their medicines from pharmacy, and they get one box of drugs or one syringe or something, they're like, what? And it's trying to explain that to someone. It's very difficult, actually. So saying that actually we can do that much quicker, because the point earlier was really good about doing it on the ward. You know, use that ward system, use your like pharmacists and technicians on the ward who can enable that close to care point of dispensing. This would, I think, save so much, and you'd probably get way less patient complaints as well.
Yeah. Okay, thank you, Laura. Alison.
Hi, I'm also not a pharmacist. And again, this is a sort of primary care based question. It's really around what we call just in case meds, so sort of end of life, both in nursing homes but also in the community. And I think I'd seen on the chat that there'd been work done in England around sort of nursing homes having central stock rather than individually prescribed just in case meds. But also, I was just wondering,
do any areas have district nurses who hold meds rather than them being in the individual patients' houses? I'm sorry, Laura, I thought your work was incredible.
Oh, thank you. Happy for someone else to come in who may know a bit more, but I do know there is loads of work being done, Alison, around care homes and wastage of medicines in care homes, because obviously we see a lot of end-of-life patients in care homes. So we actually have done audits. Someone I know and that Nuala knows as well last year did a huge audit around care home medicines wasted, and the figures were shocking. So I think it's around doing that work. It's never, unfortunately, easy, as I'm sure everyone on this call knows, especially to drive the sustainability agenda. So it's actually saying, okay, I'm going to do my audit and I'm going to show you just how stark those figures are. And that really gets the attention of people then to say, actually, this is huge wastage, huge waste of cost, huge waste of everything. And then getting that onto a table to say, how are we going to solve this problem? And as Helena said, it's almost like we all need to group together and say, this is a huge problem. We know that actually it's very simple just to say, especially for places like care homes, that's a controlled area. Can we take those medicines back to a hospital? Everything we do, of course, is not done without the quality aspects. So those, of course, would be looked at by someone with appropriate knowledge to say, I've checked this coming back into stock. It seems appropriate. It will be dispensed again. It will be checked again. It will go through all those touch points to make sure that it is appropriate. We aren't just going to send it out to another patient straight away. We'll still do all those checks that are appropriate. So I think we just need to keep pushing this agenda, as Nuala said.
Yeah, absolutely. And we at CSH, we're currently doing a medicines waste and care home project, specifically looking at the environmental and social impacts of medicines waste. So we're at the data collection stage of that at the moment. And there's lots of issues, and I would say they're generally sort of, again, systems issues and the way the systems are set up and the dispensing systems and the ordering systems. And there's definitely lots of challenges, and you can see what seems to be a simple solution is actually quite difficult to implement because the way the system is set up. But we're certainly looking at we will be bringing out sort of recommendations and education resources around that. The end of life meds in care homes is particularly tricky because they're controlled drugs. So care homes can't sort of just hold stocks of those. They have to be prescribed for specific patients. And obviously there's an element of sort of the unknown there. So people tend to over order, particularly at the weekend, because they don't know how much the patient will need or when they'll need it, etc., etc. So end of life drugs are definitely coming up as a significant issue, and that's come up sort of in several sort of different settings. I don't know, is there anybody else in the room who's got experience of working in care homes would like to sort of say anything else about that? I mean, I know certainly during COVID, they relaxed the rules around the stocks that care homes could keep, just because of the situation that we were dealing with during the pandemic. So sort of it is possible. And as Laura says, it happens in other countries. And so again, I think it's about us challenging upwards to get people to look at the regulations. Just because we've always done it doesn't mean it's the best way to keep doing it. Anybody want to make any other comments around the care homes and stocks and care homes? I don't see anybody putting up hands. But yeah, lots of people looking at that, Alison, and hopefully we've definitely got lots of interesting data. So I'm hoping we'll come out with some useful recommendations from our project, which is due to complete in around June.
Okay.
And can I just say as well, it's so lovely to have so many non-pharmacists here on our Pharmacy Network event, and you're all very welcome. It's great to have the multidisciplinary team. Laura, there's a bunch of questions in the chat box, so I'll go through those. So Paul, who did freeze earlier, so Paul was the one who was speaking to us from a hospice, and he asks, do you ever see a time when drugs brought in by patients could be reused? I apologise if this question was asked while I dropped out. So reuse of patients' own drugs in hospitals. I know we've certainly got some SUSQI projects on the network on that. Do you have experience of that, Laura, in your hospital?
I don't have any experience of that personally in King's, no. But I sort of I'm quite risk averse for a pharmacist, which may not shock you. But I think I always find, and I know I've probably banged on this drum, but if you have appropriate risk assessment and the appropriate evidence to show why you're doing it and you can back that up, no one's going to come and say you can't be doing this. I think if you can show valid reason and safety to say, actually, this is why, this is how we assess the risk, this is who has signed it off. We've been in touch with all these, like you just said, the MDT. We have to trust our healthcare professionals as well. I think pharmacists are very like, we need this ownership, but actually, we trust our nurses on the wards. Like I said, you can never fully guarantee something, even ward stock. Like there's so many medicines on wards, and everyone, sometimes I get the challenge of how can you know that it's been kept at this? I'm like, well, how do you know when a nurse dispenses a tablet that's been on a ward for X amount of months has been kept? You don't. So I think there's that element of like trust and using your own knowledge to say, I've assessed it, or someone else has looked at it and said that they feel it's appropriate. We all have that knowledge to do so. I don't see why we wouldn't utilize that.
Mm-hmm. And there's certainly several examples on the pharmacy network. So if you go to the resources and look at the pharmacy network, and if you filter by the SUSQI case studies, there's a few case studies on reuse of patients' own drugs in hospitals. So some hospitals actually have a policy of encouraging patients to bring their own medicines in. This is generally their sort of oral tablets for chronic diseases, and means that when they get into A&E and they're on a trolley in the corridor, they might actually be able to take their normal dose of their medicine when it's actually due, as opposed to waiting for it to be dispensed from pharmacy. So there's definitely several examples of that on the network at the moment. Nick.
Just really to echo that point, Nuala, I've been out of secondary care for a while, but when I was clinical pharmacy manager, we had been reusing patients' own for a number of years. As you say, it improves access to medicines before pharmacy can get there. But the principles that Laura's helpfully explained are absolutely right. A risk assessment and a protocol, and pharmacy staff who can eyeball that medication as soon as is reasonable after admission. But that one of the main reasons was the cost improvement project, that we saved significant amounts and could demonstrate that by a periodic snapshot audit. So yeah, if it's not been talked about in your area, talk to your pharmacy staff, because it's well established practice now, so they should be able to work with you on it.
Yeah, absolutely. Great. Thank you for that, Nick. Okay, let's have a look at the chat box. So somebody's just commenting, in terms of reducing waste in primary care, is to only prescribe maximum of 28-day supply at a time, because a lot of the time changes happen just after picking up a 2 or 3 month supply, and then there's lots of waste, and that all has to go to be incinerated. CIP cost improvement program. Somebody asking, Flavia asking, do you have any suggestions to recycle drug wastage in operating theatres?
Good question. Recycling drugs is also a very interesting topic as well. So at the moment, anything that's like got any medicines trace on it can be recycled. Again, MHRA are very strict on that. There are some schemes around recycling of things like tablet packages, and some really good things around that. I don't know anything about like operation theatres, so probably you're thinking more IV, more sharps and steriles and things like that. But I do know there are some schemes where you can buy in really great like little cardboard bins, and you can put your tablet packs in there, and those can be recycled. It's actually a very cost-effective scheme. It's not very expensive to do. So that's the only one I know about at the minute in terms of recycling medicines. And inhalers is a different area that they can also be recycled. But yeah, it's a MHRA are quite strict on it. So I think we're getting better. We have these like certain schemes running in different parts of the country, but I think that's where we use our voice as healthcare professionals to keep pushing this agenda.
Yeah, absolutely. And I think the other thing to think about there, Flavia, is how you avoid creating the waste in the first place, because that's much more impactful than trying to recycle. So there's certainly, again, been some SUSQI projects around rationalising the medicine stock in theatres and looking at what's actually used and what's actually needed, and then sort of taking out stuff that's being wasted or is only rarely used, and also looking at the sort of process within theatres in terms of opening stuff up before you actually know you're going to need it, and then you don't need it, and then it gets wasted. So that's kind of another route to take, is to kind of do that sort of audit of usage and then try and reduce the waste being created in the first place, if you like. And again, some examples of that on the SUSQI resources on the networks. Just another couple of comments on here, Laura, around the disposal of drugs at high temperature, especially the oncology drugs, is one of the most expensive waste streams, and obviously also really high in terms of CO2 emissions. So kind of factoring that into your calculations then kind of ups the benefits, both in terms of cost and CO2 savings. So it'd be really interesting, actually, I think, to do a really kind of proper in-depth carbon footprinting of this whole sort of project and all of the different impacts.
I think being an aseptic pharmacist and also a sustainability person is heartbreaking, because we are the worst probably offenders, certainly within the pharmacy sector. So yeah, it's finding those ways that you can reduce it. And for anyone that does work in that sector, there's some really good work being done by SharpSmart. Whilst we still have to do high cost incineration, they have reusable containers for hazardous drugs, so at least we're not burning the plastic as well, the plastic bin. So SharpSmart is a great for any pharmacy waste, actually. They're reusable, so that's also really good in terms of that.
Yeah, great. Yeah, and all the single-use plastic is just kind of soul destroying, isn't it?
Heartbreaking. Yeah.
Yeah, and then just a few more comments in the chat about recycling of blister packs, which is very complex. Some community pharmacies are accepting those for recycling, some Boots, I think mostly just down in London at the moment. Some of the Superdrug branches were as well. I'm not sure if that's continued on, but that again is a really complex process, because it's sort of plastic melted to aluminium foil, so it's really difficult to separate them and then recycle them. So yeah, a tricky one. Okay, have we missed any questions, Eva? I think we've covered most things in the chat.
Yeah, there are some in the Q&A section.
Oh, mine is just opened up.
I think Komal asked about if you have been able to calculate the carbon impact in tons of CO2. I think you sort of answered the question, haven't you?
Yeah, so I haven't actually quantified that yet, but it's something I'd be really interested in doing. And certainly because we have the data, I'm hoping it would be something that we could get, probably quite a rough figure, but I think it would be huge, if I'm being honest, because of the resource that goes into the production of a sterile medicine. It's insane. And like I said before, it's that 4-hour time to get one tiny syringe, and patients kind of look at you like, this took 4 hours, but that, the amount of resource and plastic and carbon that went into it is hugely intense. So definitely something for me to go away and work on, because I have the data. So hopefully something I can work with Nuala on, maybe to get you some more data around that.
Yeah, and I'm wondering, Laura, is there any, the way Greener NHS have got obviously all the stuff on their website and some specific case studies, is this one that I don't think it's one that they've covered. Is it worth taking up with Greener NHS as well for that sort of more widespread?
Yeah, definitely. I think it's definitely a conversation we can have with them, because also if it's one thing me sharing my resource, but probably if they worked on a generic one for everyone, a generic risk assessment, a generic SOP, a generic process to follow, it would probably encourage a lot more people to do it as well. Well, it really should become standard of practice, not something like a project. It should just be the norm, really.
Absolutely, yeah. Because I think like you say, lots of pharmacists are risk averse, and they'll just go, "Oh, reusing? No, we're not going to do that." So having that weight of Greener NHS and a kind of validated process, I think that would really help sort of break down those barriers, wouldn't it? Definitely a conversation to have. Okay, any more, Eva?
Yes, there is a question from Natalie, and it's about we adopted a reuse of medication procedure in March. Feedback from staff has been that the process is paperwork heavy. We asked them to fill in a form per item, which is essentially a checklist that the product is suitable. This is in addition to the paperwork which shows the item coming into pharmacy, then going out when it is reused. Would you say the assessment form is necessary to prove it's been assessed, or do you use the spreadsheet you mentioned to track products in, out, and the batch number? Sorry for the long question. She apologizes.
No, not at all. That's a great question. And so, yeah, I totally, I think you're right. I think, yeah, it can be a bit more paperwork heavy. So what we actually do at King's is we have the staff from wards that return the drugs to us, and we put them in like a separate part of the fridge or the room temperature area, and they kind of are in a thing that says medicines for reuse. That's what it says. So we then keep a spreadsheet of that. So it's tallied on a spreadsheet, and we know if we have another patient come in, we look at the spreadsheet, we say, oh, we actually have one of those in our cupboard. So only at that point, actually, do we go and assess it. So at that point, we'll say, okay, we can actually redispense this for another patient. So we go, we look in the fridge, we take it out, and then it goes through the formal check. So at that point, if I took it out of the fridge and I'm like, oh, it looks like snow globe, there's precipitation here, bin, we're going to have to make it from scratch. But we do that when we have a new patient for reuse. And that just kind of saves the burden of when it comes back into pharmacy, getting someone who may not be the most appropriate person to do it and having to add time onto their busy day to look at it. So it kind of goes straight back into a holding area, and then only when it's ready for potential reuse, then does it get assessed properly. And that goes through dispensing, and like I said, another check as well. So you've got at least 2 touch points of someone making sure that actually this medicine is fit for reuse for another patient.
Thank you.
That answers the question.
Yeah, we do ours the other way around. So we have the ward-based pharmacy technicians who identify, they go onto the wards, the bins that nurses put in when people are discharged, they'll go through. If there's any full packs, they'll do an assessment.
Brilliant.
But then they fill in paperwork to say they've done the assessment. Whereas if you think about like a patient's own drugs assessment, when people are admitted, we don't fill in paperwork. The assessment just, it's that trust of staff, isn't it, that they understand how to assess something as suitable for reuse, and then we put it back on the shelf in the pharmacy, which is the designated recycled storage area. So really, because we've been running the procedure for a few months now, and one of the barriers to implementing the procedure is the paperwork. So I was wondering if we could drop it and replace it with a spreadsheet that sort of tracks things in and out.
I don't see why not. Like, it sounds like you have a really robust process. So I would say if you have a detailed SOP that details that process, that you're covered by that, because as long as people have like signed and, data to say, I've read and understood this procedure, as long as they're following procedure, then you're covered, because you've mandated in that procedure. The slide I had, which was all the bullet points, you state in that procedure exactly what needs to be done. It's, it's not been tampered with. Everything looks fine. It's got X, Y, Z. If that's all covered in your procedure, and they're following procedure, and they've signed to say that they will follow procedure, I don't see why you wouldn't be covered by that.
Thank you.
And we then had one last question. Has the trust explored the recycling of inhalers? And I've seen, Nuala, you just put in a link to the new inhaler recycling project launched to combat climate change in Southeast London. Do you want to say a bit more to this, Nora?
That's actually me.
Nora can speak to that also.
Yeah, clearly I just love my job. So that is actually something that I'm working on, the Southeast London inhaler recycling pilot. So it's a piloted scheme by NHS England, and we're working on how we dispose of inhalers basically. So we are doing a pilot with 20 community pharmacies and all the acute trusts within Southeast London. And we're collecting as many healers as we can back from patients, and then we send them off to a site which will repurpose and reuse all the materials. So the plastic and the aluminium will get recycled, and then the contents of the inhaler, the HFA gas, which is the environmental pollutant, that actually gets recycled in a big container and then reused for things like refrigerants. So instead of putting that harmfully back into the environment, we're reusing it for good purpose. So we're trying to pilot this to get some good data and hopefully be more successful than other schemes that have worked around a 5% return rate. So far, we are seeing more positive results than that. And the idea is, again, we pilot this, it's NHS England data after that, and then we write it up and it just becomes standard of care. So inhalers should be returned to your pharmacies, your hospitals, and then we just collect that waste separately, and it just becomes the norm to recycle our inhalers that way. And then we're not, those inhalers aren't going to landfill, the gases aren't depleting our ozone. So that project's going really well. And hoping in the next 6 months or so, we'll see and like the write-up being done. So we're giving all our data back to NHS England, and they will hopefully do the write-up as well. So happy to take any questions on it, but I can't really say too much about the data, unfortunately.
Okay, brilliant. Thank you, Laura. That's a great piece of work. Lots of people looking forward to the results of that, I think. So I've just popped in the chat some links to SysQI projects around the things that we've been talking about. There's a little bit more chat around recycling blister packs and people connecting up as well in the chat, which is great. Somebody asking, Helena's asking, Laura, are you funded as a sustainability lead or QI pharmacist, or are you doing this as a hobby, which is what we're most of us doing, isn't it?
Yeah, sadly not. My boss is very supportive, I have to say. So I did convince him to give me the title of Medicine Sustainability Lead because of all the projects that I've been working on. But no, just something that I'm really passionate about. So really keen to do more. So, you know, like probably everyone in this chat, we do a lot in our spare time because it's important to us. But I will say my boss is supportive. So there's definitely plenty of times in work where I've dedicated time to sustainability projects as well as my actual job. But yeah.
Well, thank you for all of the amazing work that you're doing, Laura. And so thank you so much for coming this evening.